This
pleasure to
conference will now
see
be
you
recorded.
again in our platform. So you can head with the presentation, sir.
Yeah, so good afternoon, everybody. This is actually a second series of previous part of my presentations. So in the first sessions, we had discussed about introduction to Amblyopia and the concepts regarding the classical concepts. I hope most of you were there in the first session. So we had just discuss we just had discussion on classic concept of amblyopia, classical definition, the functional definition given by Coffidia, and the behavioral definitions. So actually we had some introductory sessions, and then uh, we just went on to the key concept or current understanding regarding key concept on management of amblyopia. So this is today is the continuation of that session. So today we'll be discussing on management of functional amblyopia. Especially, I like to go with the anisometropic and the uh, anisometropic and isometropic amblyopia, refractive amblyopia. Today, because the management part is very vague, we'll just like to concise on only isometropic and the refractive type of amblyopia. So yeah, so at the previous presentations, we ended our sessions with the three keys for the management, three keys in the management of the amblyopia. So what is that keys? The three keys were the lens prescriptions, the use of occlusions, and the optometric vision therapy. That includes monocular fixation in a binocular field and the binocular therapy. So today we'll explore in these all three basic aspects: the how we'll make a decision in prescribing a correct lenses to the patients, how we properly use occlusion as our therapeutic treatment part in patients with amblyopia, and so how we'll go with the vision therapy part and go with the complete management of the refractive amblyopia. So coming to first, lens prescriptions. I hope we all have come up with many cases of refractive amblyopia. So after diagnosing, after evaluating the patients, so the first this is the first steps in management. So this first step plays a vital role in afterwards management of amblyopia. So the lens prescriptions is basically based on a distance retinoscopy. In most of the cases, cycloplegic corrections is also done, and subjective refraction and near point retinoscopy. So how the lens prescriptions is made is that, so we should not, for example, the patient has is emmetropic in one eye and the patient has +7 +8 refractive error in the another eye. So it's not mandatory that we should prescribe a full corrections, because a full prescriptions will have the difference in refractive error between the two eyes will be very high, and the image size magnifications and other many factors matters. So we undercompensate the prescriptions until the fixation is steady and centric. And refractive compensation is based upon minimal compensation to achieve a maximum binocular results. As in the previous sessions we discussed, the main key things that the main key things that we achieve or we need to achieve in patients is binocularity. So refractive compensations or refractive prescriptions should also be based with the aim to achieve a maximum binocular results in these subjects. So basically, when we, for example, there is a case. So again, I like to repeat that case. One eye is don't have significant refractive error, has a refractive error of +0.25, and the next one has +5 or +5.5. So after performing a cycloplegic corrections, so on subject on doing a subjective refractions, so we should perform these different tests of binocularity to determine the final prescriptions. The main thing there are, I have listed three tests: stereopsis, Watford dot test, and VO star. So basically, we can do two tests that are common in our hospitals or clinics or outlets. So we can perform a stereopsis and Watford dot test. during performing a subjective refraction and determine which amount of prescriptions will help the patient or will help the child to attain a maximum results in binocularity, and then will prescribe the prescriptions according to that. Again, in that case, for prescribing of plano in one eye and plus full prescriptions in the next eye will result in decreased binocularity in these subjects. Maybe in workflow notice the child will have a suppression in his eye with high refractive error. So we have to decide prescriptions on basis of these tests of binocularity, workflow dot test and stereopsis. So the goal of prescriptions, the main goal of prescriptions is to reduce the binocular competition and improve the binocularity in these subjects. So making a image, prescribing of full prescriptions sometimes may not help the child, and we should make a decision on basis of these tests to attain or to reduce the binocular competition and improve the binocularity in patients with amblyopia, in the patients with amblyopia. So if we can go for a contact lens option, especially in anisometropic child, it is always a better option, because one thing is a difference in lens thickness, and another thing, the main thing is freedom for a patient. And again, the next important thing is a retinal image magnification. So if we can consider a contact lens, even a small child awareing the patient parties regarding the usefulness of contact lens for a child with amblyopia, that would be very great. So I'll always consider a contact lens for significant anisometropia. But if it is not possible, then undercompensating the prescriptions with maximum binocularity will very much help the child. So again, when evaluating if the child has, if amblyopic child has very much a reduced accommodative response, especially this maybe in the case of isometropic types, then bifocal prescriptions can be incorporated in the prescription. So basically the main aim of the lens prescriptions is again to decrease the binocular competition, and the work starts from the first steps of lens prescriptions. So the lens prescriptions should always be based, we should always make a decision of making lens prescriptions on the basis of performance test like stereopsis and workflow dot test in subjects with amblyopia. So the next step is the occlusion. So in a previous sessions, so we just had discussions regarding the many things, discussions regarding the disadvantages of occlusion therapy. So what does occlusion full-time occlusion, what does total occlusion do? So what disadvantages will it have in attaining a binocularity status of the patient? So what effect will it have in the quality of life of the patient? So what effect will it have especially on the field of view of the patients, especially in the performance of the children? So basically occlusion can be used very wisely. It should be used wisely, because as I'm repeatedly saying that our aim is to decrease the binocular competition and reduce the binocularity. The more the occlusion time, we will have less chance of improving the binocularity in the patient, because in occlusions only one eye will be using, so the binocular cells cannot be activated. So basically there are two types of patching that can be done. One is direct occlusion, and the next one is indirect occlusion. Basically indirect occlusion is used in a child or the patient with a steady eccentric fixation, and when direct occlusions and vision therapy are not showing improvement in visual acuity. And in direct occlusion, we basically patch a non-amblyopic eye and allows stimulation of the amblyopic eye, and it helps in reducing a competition or inhibition from the non-amblyopic eye. So how to go with the occlusion part, especially in amblyopia? So basically I don't recommend any total occlusion to be done to the amblyopic subjects, even it is very high or it is very severe. So a partial occlusions will be very much helpful for the patients, in which the vision is degraded or blurred, but the retinal image formation will be still present. So in these cases, different tools like Bangalore foils or frosted lens has been used. But the availability of these kind of Bangalore foils, and especially Bangalore foils, we can get Bangalore foils according to the grading of visual acuity in the market. But I don't think in Nepalese market we have such very good facility of the binocular foils. So basically what I'll do is I'll just to improve the binocularity or to initiate our occlusion therapy. What I have started doing is I'm just over plusing optical corrections by about plus 0.5 or plus 1.5, either incorporating, especially incorporating it into the spectacle prescriptions, so that the vision of the good eye will be a bit deteriorated than his normal one, and the non-amblyoptic eye can better compete with the good eye. So basically, in partial occlusions, the vision is degraded or blurred, and retinal image formation is still present. But apart from this binocular foils, we especially use a bit overplused optical corrections that is very much easily accessible towards us, and on frequent examinations will make changes in accordance to the prescriptions. That will also work as a partial occlusion. So for a non-amblyoptic eye, to a level below that of amblyoptic eye, usually 2 lines lower than visual acuity, because incorporating especially a +1 prescriptions degraded the visual acuity of the good eye by about 6/9 parts, and I hope the child will not have such more difficulty in incorporating that prescriptions. But I'll be much aware regarding locking a child in a hyperopic. So we don't want to lock in the child to be hyperopic also. So on every follow-up examinations, we'll work whether the child is okay with that prescriptions or not. That we have aimed for partial occlusions in the spectacle prescriptions. So there is a questions regarding the way effect on binocularity by the constant occlusions and its effect on performance of the light. So basically, what we do is we just go with the minimal occlusions for the patients. But if the patient is the first time comer to us, what we'll do is we'll just go with the part-time occlusions. If the child is a first time comer, for example, after the lens prescriptions, if the patient has after the evaluations after the evaluations lens prescriptions, and we'll ask the patients to come to the follow-up, and on the follow-up during follow-up time will be of 3 weeks to 1 month. So on that time period, we just ask the patient to go with the part-time occlusions to the amblyoptic eye. Especially why this is done is, and this is mainly done to know the compliance, to determine the motivational status of the patients. Actually, that these occlusions will plan always to remove that occlusions or stop that occlusions on the follow-up. But our main aim will be to judge the motivational status, whether the patient will be in compliance with part-time occlusions or not. And finally, we'll go to the minimal occlusions, especially during specific vision therapy procedures. We'll occlude the patient's eye. Otherwise, we'll put the patients on the partial occlusion. So basically, first step is the lens prescriptions or proper lens prescriptions on the basis of performance test, and the next one is choosing a good occlusions, good way of occluding using occlusion therapy to the patients. That may be a partial occlusions, or that may be a constant occlusion, especially the part-time occlusion. So what is the best approach? How to go with the patching? How to go with the occlusion therapy to the patients? There is an article entitled as a new form of rapid binocular plasticity in adult with amblyopia. The article suggests that the best approach is no patching. So basically, I have kept this point of minimal patching is will not go with the occlusion therapy. Basically, we'll do the minimal occlusions, or if we need to incorporate, we'll incorporate partial occlusions as over plus optical corrections in the patients and use no occlusion. So the third step is the active vision therapy. So I will how will go forward after the lens prescriptions, and we'll ask the patients on the basis of the patients, how the patients can come us to the follow-up. it can be, the range can be from 1 week to 1 month, either 3 weeks to 3 months. If the patient is from very far, we'll go a bit longer follow-up. If the patient is very near to us, we'll go for short follow-up and go with the partial occlusions, or that the part-time occlusions, and will take the patients onto the follow-up. And our next steps in patient with refractive amblyopia, that could be isometropic, and an isometropic amblyopia will be a active vision therapy. So the purpose of, what is the purpose of therapy or the active vision therapy? Is to maximize the patient's performance in visually related tasks such as academics, sports, and driving. And successful treatment can be accomplished, and a long-term cure sustained is if the emphasis is on developing high degree of binocular functions. And if we'll incorporate this active vision therapy in the management part of this refractive amblyopia, the conventional approach of occlusions and full optical corrections will be not needed. So what is the purpose of active vision therapy for amblyopia? So I have listed out some of the purpose. The first one is to enhance the effects of occlusions. If occlusion is done, especially if we have if we undergo the part-time occlusions to the patients, the purpose of active vision therapy will be to enhance the effects of occlusions. And the next purpose is to decrease the total treatment time. And the next one is reduce symptoms, improve visual performance deficits. And this visual performance deficits means during evaluating, we'll evaluate the many visual efficiency skills in these subjects. So our main goal of the active vision therapy will be to improve the these visual performance deficits that the child or the patients will have during the evaluation part. And the most importantly, the main purpose of the final but not the least purpose of active vision therapy for amblyopia is to maintain gains. To maintain gains means, for example, we have a patient initial correction sequence. We have the patient with anisometropic amblyopia. In one eye, the patient has 6/6 vision, and the next eye, the patient has 6/24 vision. So what does the gain means is, after undergoing the therapy, so for example, the child will improve to 6/12 or 6/15, and if the to maintain gains means to maintain that improvement to that level, not to regress the improvement. So these are some of the purpose of the active vision therapy. And what VT procedures would you do after determining the purpose? What is the purpose of active vision therapy in these subjects? So the another thing is, what VT procedures would you do in these subjects? So these vision therapy procedures will be what procedures that we do will be determined by the evaluation part. So this is a last slide from the last presentation itself. So basically, the primary deficits in amblyopia are the deficient eye movement and fixation skills, steady or eccentric fixation, increased saccadic latency and reaction time for eye-hand coordination, decreased pursuit accuracy, poor form discrimination due to decreased contrast sensitivity, the deficient accommodative skills, decreased amplitude, accuracy, and decreased sustaining ability, increased accommodative latency, spatial uncertainty, and increased contour interaction, and reduced visual information processing speed and ability. So these are the primary deficits that are found in this child with amblyopia. So our aim with the vision therapy will be to improvise these deficits that the child has. So VT again. So the aim of vision therapy is to change the neural connections in the brain. Basically, this is the thing that I had discussed in the previous sessions also. So the main aim of doing VT is changing the neural connections in the brain. So there is a statement in the book called A User's Guide to the Brain that to change the wiring in one skill, you must engage in some activity that is unfamiliar or novel to you, but related to that skill, because simply repeating the same activity only maintains already established connections. Our brain are wonderfully plastics throughout the adulthood, and the brain has a tremendous ability to compensate and rewire with practice. That is a statement by John Ratey in his book The User's Guide to Brain. So what does so how does this thing is connected with vision therapy is, so in vision therapy we'll go with some of the activities that is unfamiliar to the child and develop skills that is necessary to complete that activity to the child. So that helps in developing or rewiring the brain connections and ultimately improving the deficits that is present in the child with amblyopia. So ongoing with a different VT procedures, the first VT procedures that has been very much you explained as very much useful in child with amblyopia is the Syntonics. Actually, this Syntonic service is not available in Nepal. So basically, I have just kept a slide so that we may have some understanding regarding it and its usefulness, especially in the amblyopic child. So this syntonic phototherapy is an optometric study and the application of specific frequencies of light applied through the eyes to rebalance the body's regulatory centers, thereby correcting visual dysfunction at their source. So this what this syntonics use is, this syntonics use a light with specific frequency, and it helps in regulating the different centers of the body and eliminating the different visual deficits that is present in the child with amblyopia. So this again, the syntonic phototherapy or the light phototherapy uses visible light frequencies, colors through the eyes to enhance visual attention and decrease the symptoms of stress and trauma. And the goal of therapy is to balance the autonomic nervous system. Especially this for syntonics acts on the pupillary level, and the goal of this therapy is to balance the autonomic nervous system, which controls our visual perceptual fields. Although we are not able to provide this kind of services to the patients here in Nepal, but this we should know that what are the helpful tools, so that helpful tools for the child with amblyopia. So I have incorporated these things here. So after this, the main thing that we are doing or we can do or we can perform to improvise the deficits that are present in child through active vision therapy here is the three kind of activities: the monocular activities or the monocular vision therapy activities, the monocular fixation in a binocular field, and the third one is binocular activities. So basically, to gain and concrete or to gain the basic understanding regarding how these three steps, monocular fixation in the binocular field and binocular therapy helps is, let's make some concept regarding in these monocular activities in amblyopic eye or the amblyopic eye, which has the deficits in different visual efficiency skills. These monocular activities helps in building confidence and self-esteem of that amblyopic eye. And this monocular fixation in the binocular field, actually what I'll be discussing in detail in the coming slides. Actually, it is a combining or the engagement. Let's say it is an engagement between the two eyes. Means from the monocular vision therapy activities will increase the confidence and self-esteem of that amblyopic eye, so that it will be able to compete with the normal eye, and then only it can be engaged. And after engagement, then the binocular therapies means using both eyes together. Let's say the marriage between the two eyes. So these three steps should always be chronological to each other. For example, if we omit a monocular therapies and directly do a binocular therapies, the building of confidence in that amblyopic eye, the self-esteem and the engagement will not be able to do that, and directly the marriage cannot happen between the two eyes. So basically these three steps should be in chronological order: the monocular fixation in the binocular field, and the binocular vision therapy activities. So in the coming slides, we'll go to the detail regarding all these. So let's go with the monocular therapies. So again, I told the monocular therapies is a process of building confidence and self-esteem in that amblyopic eye. So this helps in restoring and building the visual abilities of that eye and restoring and building confidence in that confidence and self-esteem in the activities. So what are the monocular activities that we should do, we can do, or we should do? The VT procedures is the main goal if on assessing the child, if the child has a eccentric fixation. In any cases, our main role is to first establish a central fixation in that child, in that eye, let's say in that child or in that eye. So what are the different activities that we can do to establish the central fixation? We can go with the Edinger process. It acts as foveal tag and gives a biofeedback to the patients about where the fovea is pointing. And the next activities that we can do is after image transfer. After image transfer activities, it acts as foveal tag, and in this after image transfer, the fovea of non-amblyoptic eye is monocularly flashed with after image, and the non-amblyoptic eye is then occluded, and then after image transfers to the corresponding fovea of the amblyoptic eye. And the final goal in these activities is to place the after image on the monocularly fixated targets. So these are the two basic procedures that we can perform or to concurrently establish a central fixation if the child has a central eccentric fixation. And there are also monocular procedures like in monocular procedures, one thing is to establish a central fixation, and the next one is there are different oculomotor procedures that we can perform, that for especially for the pursuits and saccades, because these oculomotor procedures are very much deficient. I told that the decreased pursuit accuracy, increased saccade latency. So these will have these are very much deficient in the patient or the child with amblyopia. So different I have listed out the different therapy that we can do, and the one that in our all clinic that we practice, we will have a prism, loose prism or a prism bar, so we can perform activities like monocular prism jumps and the line counting, the hard chart saccades, the pegboard rotator or the pursuits. We can actually, it is an automatic pegboard rotator. We can also make this pegboard manually by incorporating a dynamo of a fan and a cardboard, so that will not be so that we could be able to train pursuits and saccades to the child. And there is a amblyopia program called HTS, and that we can perform either at the office or at the home. So some of these activities we can perform or incorporate at the office therapies as the office therapies, or some of the activities that some of the activities we can ask the patients to do at the home. So basically monocular prism jumps, line counting activities, the hard chart saccades, pegboard rotator, the HTS, INET amblyopia program, the tracking books, and the saccadic strips. So saccadic strips are like this. We can train a pursuits and saccades. So these are the basic oculomotor procedures that we can do or we can perform to enhance the oculomotor status of the child. So next, again, the monocular again, let's not be confused. Monocular therapies, I discussed how to establish a central fixation and then proper oculomotor functioning. And then the next procedures that we should do monocularly are the accommodative procedures. So these are all very much elaborative procedures. So I have just note down the procedures that we can do. So if anyone is very much interested in doing all these, or in knowing the instructions how to do, so I can share after post sessions in the mail or something like that. So in accommodative procedures, one thing we can do is a bullseye procedure. So this is a child doing a bullseye procedures. Well, we'll place a transparent sheets and ask the patient and place a distance target and ask the patients to make the things clear. And the next procedures is the lens sorting, and in these procedures we put a put a different series of plus minus lenses and ask the patients to arrange the lens according to that. And the next procedures that we can do is a minus lens that will helps in increasing both the amplitude and facility. And the next procedures that we can do in the accommodative procedures for the child with amblyopia is the near far rock as shown in these pictures. And the lens after improving a bit improvement in all these things, we can go with the lens flipper that will helps in increasing the facility, and also a watch mental minus that helps in getting or the feedback to the patients regarding his concrete accommodative activities. So these are the basic accommodative procedures that we can incorporate in our practice for improving the accommodative status of the patients: the bullseye, the lens sorting, the minus lens, near far raw, lens facility, flipper that helps to improve facility, and also the stability. And the next one is watch mental minus. So the next category of the monocular therapies activities that we can incorporate, basically some of these procedures, especially the accommodation procedures, are especially performed as the office procedures, and these pursuits and saccades can either be performed as the office therapy procedures or the home therapy procedures. And the next one that we can go is the eye-hand coordination procedures, and especially this includes the basic therapies like coloring, cutting, drawing, and tracing, stringing beads, serials, or buttons. There are different computers and video games, the pegboard activities, sewing, needlepoint, lacing cards, dot-to-dot procedures, mazes, and coloring O's in the or the crossing outs, the letter in the newspaper, road maps or line tracing. Again, the watch finger thinking procedures and different chalkboard activities. Some of these procedures can be performed in the office, and some of these, especially the procedures like coloring, cutting, drawing, the computer and video game, can be done on the done as a home therapy for the child. So the first, again, the establish the central fixation, the oculomotor procedures, and the next one was the accommodative procedures, and then the eye-hand coordination procedures. And the next category is the form recognition and discriminations procedures. Especially these are the activities that require the resolution of details. The main emphasis in these procedures is the recognition of form, but complicated with being hidden, briefly exposed, or slightly different from similar comparison form. And the VT techniques that can be used to improve the form recognition and discrimination skills are the tracking books, word or letter sources, form reproduction, and highlights for children magazines, especially hidden pictures, similarity difference activities, and the tachyoscope. So these are the different monocular activities that we can perform as an active vision therapy procedures, either some incorporating it as a home therapy procedures or some incorporating it as a office therapy procedures. So it depends on the child or the parent, understanding of the parent, the understanding of the child, the cognitive level of the child, which therapy procedures you decide as a office therapy procedures, and which therapy procedures you use as a home therapy procedures. And the one after working, especially working on these amblyopic eye, let's not forget to work on the good eye also, and not just the amblyopic eye. If there are symptoms like if there are symptoms like blur during the other time, like during going to school or on other inactivities, if the patient complains the symptoms of blur, the loss of place while reading, difficulty with reading and composition, we should find out that the symptoms are coming. We should rule out whether the symptoms are coming from the non-amblyopic eye or not. So after working with all these monocular activities procedures, especially the fixation, the accommodations, the oculomotor, the hand coordination, the form discrimination, and then we'll actually these are the list of therapy that I have listed out. So some might be some practice, some vision therapy practice, or some clinic or some hospital can practice or incorporate some therapy procedures, and some can practice the different therapy procedures. But what we should do is, after performing or doing after in during performing all the monocular therapy procedures, we should evaluate the child in a regular basis. Especially we evaluate the child, especially in a 2 weeks to 3 weeks. Especially I evaluate the child in a 3 weeks period and see whether there is any improvement or there is any gains in the deficits or thing that the child has, especially on the evaluation part. And uh, will on the basis of that will proceed to the next step. So how to make a decision whether to proceed in the next step or not is that, for example, I like to explain that with example. For example, again, as the previous example, the one eye has a plano plus 0.25 refractive error, and the next eye has 5.5 refractive error, and the visual acuity is 6 by 36. Let's say the visual acuity is 6 by 36. So on refractive corrections, the visual acuity improved to 6 by 24. Let's consider like this. And on doing the monocular therapy procedures, on evaluating the child in a 3 weeks period, the visual acuity, let's say we find it 6 by 18 only. And then what we need to consider is, we need to consider on an individual basis whether to continue or whether to stop the monocular therapies. So if the visual acuity is 1 by 6 by 18 and the performance of the child during all the vision therapy procedures is not that much so good, then we'll plan to again continue the monocular therapy activities, and then until the patients reach like the visual acuity of 6 by 12 or something like that, we will continue the monocular therapies procedures. And after the more than 50% to 60%, let's say 60%, more than 60% improvement of the deficiency in visual skills has been attained through monocular procedures, then we'll go to the monocular, the next steps in the vision therapy, that is the monocular fixation in the binocular field. And basically it is the procedures of engaging both the eyes. So the goal of monocular fixation in binocular field is to reduce the non-amblyoptic eyes inhibition of the amblyoptic eye. Now what we were doing is, and the next thing I just forgot to discuss is, in doing all the monocular therapies procedures, we occlude the non-amblyoptic eye. So I just discussed about minimal occlusions or minimal use of occlusions during the vision therapy procedures. So during all monocular therapies procedures, we'll just occlude the good eye. So in this MFVF procedures, and the goal is to reduce the non-amblyoptic eyes inhibitions of the amblyoptic eye, and the MFVF techniques allows both eyes to see peripheral objects. The eye can only see the central details, and this frequently results in additional visual acuity improvements and other visual efficiency skills improvement, and also it increases the possibility that the acuity gains that we had made will be maintained for long period of time. So basically, the principle of these MFVF procedures is a unified peripheral visual field is presented to the both eyes, and a central highly detailed target is seen only by the eye that is usually suppressed. And if the target is seen, then the eyes that is normally being suppressed is working. So basically, it is to the goal of these procedures, after improving the monocular visual efficiency skills, the goal is to decrease the inhibition to the amblyoptic eye from the non-amblyoptic eye. So these are the procedures that we can basically do in MFVF procedures. We can either use basically we can use an anaglyphic target or a red filter to do all these things. So we'll place one kind of target to the one eye, and the next type of target to the other eye, but the details, the peripheral field is not occluded, but the central details will be only seen by the eyes with amblyopia. So in this first picture, we can see that this is a line tracing, and we can do it with the red green glasses. So again, this is a procedures we can use with the red filters or the green filters. And this is a iNet software, Amblyopia iNet software, that has basically also has a monocular fixation on the binocular field procedures. And in this we can see all the letters are blue in color. So in doing these exercise, if we ask the patient to use red and ask the patient to do these procedures with the red blue glasses, only the amblyoptic eye we can adjust the spectacle with which filter to keep, and we can make only the amblyoptic eye to work and see these central details and perform all the therapy procedures. So basically these MFVF procedures, the goal is to reduce the non-amblyoptic eyes inhibition of the amblyoptic eyes, so that we can use, or the brain can receive the stimulus from the both the eyes. Actually these MFVF procedures, there are many, let's not say many, there are few softwares that are available, especially in Nepal. The anaglyphic based softwares and the vectographic or Polaroid based softwares. There is an anaglyphic based softwares called Visio Prime that also has MFVF tools that we can perform, especially in the child, either as a home therapy technique or as a office therapy techniques. Or if that is not available for us, we can just make these kind of tools and work on the patients with increased discriminations, and the main goal will be to inhibit the to decrease the to reduce the non-amblyoptic eye inhibition to the amblyoptic eye. So the next after again when to proceed from first to next step is the after significant visual acuity. After doing these MFVF procedures, it's not mandatory that we need to only do the monocular MFVF procedures. We can also incorporate and do monocular as well as MFVF procedures. But after doing these kind of procedures for a certain period of time as a home-based therapy or the office-based therapy, we'll again evaluate the patients and see whether there has been significant improvement and in the binocularity status and in the deficits, visual function deficits like accommodation, the eye-hand coordination issues, the oculomotor issues. If there are some improvements, then we'll go to the next phase of vision therapy, that is binocular vision therapy, means the marriage between the two eyes. So in binocular therapy, the sensory fusion and stereopsis maintains the gains from the vision therapy. And stereopsis, the importance, there is very much importance or the high amount of importance of these binocular therapies for the complete management of the patients. So it implies the uses of the sensory fusion and the stereopsis. And the stereopsis is not just the taste of depth perception, but it is also a very sensitive probe to the quality of binocularity of the patients. So in a book called Boris Clinical Refraction, there is a chapter called Barometer of Binocularity and Visual Function. The stereopsis has been defined as it is a single best indicator. The importance of stereopsis has been defined as the stereopsis is a single best indicator of the overall function of the both sensory and motor portions of the visual function. So the importance of stereopsis, we should importance of stereopsis in the quality of binocularity status the patient has is very important. Again, in the next chapter called Fusion and Binocularity, the stereopsis, there is a statement called the stereopsis contributes to the judgment of depth and distance and participates in the recognition of solid objects as compared with monocular viewing. Binocular vision and stereopsis also helps to provide motor control when reaching for the target or completion of the fine motor tasks, and it also provides for quicker and more accurate cognitive information. So we can see these statements basically highlights the stereopsis not only a test of binocularity, but also as a test which helps in different other aspects, especially the we can see the good stereopsis will also helps the patient in doing fine motor tasks, and also it also helps in providing quicker information for cognitive tasks. So these basically binocular therapies helps in improving the stereopsis status of the patients. So the aim is to eliminate any remaining suppression on the binocular conditions and stress anti-suppression aspects, especially the fine central suppressions that the patient has, especially in the case of refractive amblyopia, and develop normal sensory motor functions and flexibility. And the final aim is to final goal is to develop and enhance stereopsis. So these are the aims of binocular therapies. So there are different techniques. So each technique is very much big. So I have listed out some of the techniques that we can do, especially in our practice. So the first one is a Brock string. Actually, Brock string is an excellent tool for especially in the case of amblyopia also, and other anomalies of binocular visions also. And Brock string, the vectograms, the trinaglyph, the aperture rule, the lifesaver cards, and also there are, as I discussed, there are also some computer orthotics tools like the VTS4 or the VisioPrime that incorporates a different binocular therapy procedures. And these all therapy procedures will help in improving the binocularity status of the patients, and it depends and it varies from individual to individual. So also which therapy procedures to start. And in the first previous sessions regarding on the introduction of vision therapy, I discussed some of the feedbacks in vision therapy, like the physiological diplopia. There are physiological diplopia, parallax, then blur. So these binocular vision therapy procedures utilize, we have to utilize that. We have to keep in mind the different feedbacks that that is used with different and these kind of tools, and then perform all these therapies after in the amblyopic child. So basically Brock string, the vectograms, and Brock string we can also do with a single bead, or to just make the patients aware about the physiological diplopia. That physiological diplopia, if the patients will be aware of physiological, if amblyopic child will be aware of the physiological diplopia, then we get to know that he has attained some kind of binocularity. So also developing some gross convergence, and the vectograms, which increases the both positive fusional vergence, negative fusional vergence, also the jump vergence, the trinaglyph. Again, this helps in improving the fusional vergence, also decreasing the suppression, the amount of central suppressions. Again, the aperture rule to increase the fusional status, fusional vergence rays, lifesaver card, and computer orthotics. So basically I have listed out some of the basic binocular vision therapy techniques that we can use to for improving the binocularity status of binocularity in patients with amblyopia. So to conclude, so let's so basically these are the three steps. The first one is the monocular steps, the next one is MFEF, and the third one is the binocular therapy procedures. If there are other issues like the issues with spatial orientation, we need to go with other different perceptual therapies, or if there is issues with visual perception, there we need to go with other different therapy procedures, perceptual therapy procedures. We need to incorporate that into the child. But since this is a sessions with the sessions of management of functional amblyopia, so if a patient has any form of refractive amblyopia, either the isometropic type of amblyopia or the anisometropic type of amblyopia, these three basic steps, these, let's not say these three basic steps. The first is the lens prescriptions through the proper, initially starting from the proper lens prescriptions, then going to the use of occlusions and incorporating these kind of active vision therapy procedures, the optometric vision therapy procedures, the monocular, MFDF, and binocular therapy procedures, we can successfully treat the child. But if the in another aspects, let's say from another aspect, the child has a strabismic amblyopia, then the issues like bilaterality and the bilaterality, different perceptual disorders will be present, and we need to work up with a more vague concept. But I hope these all the procedures that we had discussed in these sessions will be very much helpful for improving the deficits or improving the deficits that the child has. And at the final, after going all through these binocular therapy procedures, our main aim is in the amblyopic child is to know the what is the amount of binocularity the child has attained. So we need to go with regular binocular assessment, especially the Oxford dot test and the stereopsis. And although the visual acuity is the secondary improvement, if we will be able to gain a proper stereopsis in these patients, we will be assured that the child has been successfully managed. So to conclude, let's not forget to treat the whole child or adult, especially in this applies especially in case of strabismic. Also some thing on anisometropic amblyopia, and we are not treating the amblyopic eye, we are treating the persons with amblyopia. And we also need to work on any problems in learning, bilateral integrations, perceptions, and many more if required. So the classical treatment of amblyopia just to treat the eyes, so not based on new neuroscience research. So improved visual acuity is attainable in majority of amblyopes, and vision therapy provides much greater chance of success without resultant performance deficits or psychological issues for the patients. And also it can improve performance and quality of life when optimal visual acuity is not achievable. Sometimes the visual acuity cannot be attained to 6/6. So but we can have some increase in performance and the quality of life of the patient. So thank you everybody. I hope these sessions provide some insights, basic insights into the management part of the let's say refractive amblyopia.
Okay, thank you so much, sir, for such a wonderful presentation. Indeed, it was a wonderful presentation for all of us. So, mm, okay. So now we are beginning with our discussion session. Let me check out how many questions you have arised here. So can you see the chat box?
Yeah, so I'll just read out the questions myself so that we can take a less time in deciding the so that it can take a less time. I can see a question from Sombir Singh, sir, what should I do to increase the stereopsis of the patients? So yeah, basically we can incorporate first in a patient means what kind of patients do you have? If the patient is amblyope, so firstly, in the initial steps of treatment itself, you cannot improve the stereopsis of the patient. So first we need to work on different monocular therapies to improve either the fixation or the accommodation or the oculomotor part, either saccade or pursuits, and then go with the monocular MFVF part of therapy, and then you can go with different binocular therapies that can increase the stereopsis of the patients. Firstly, initially you cannot go with the directly working on the stereopsis part of the patient. So the next question I see is the right eye amblyopic patient with strength of suppression is 0.9 logMAR. In this, how much percentage of tint should be prescribed? So I think Jagdish Sahani sir, so you are talking about the neutral density filter or something like that. So it depends again it depends upon all the factors. No, I don't think not only the strength of suppressions plays a factor in prescribing how much tint. And I didn't actually get what type of tint you are trying to ask with me. So maybe this point can be considered, and I'll just let you know if anything that I can answer you. So the next question I have is from Ananta Podil. As described with various procedures for VT, how can we know that one procedure is better from other, or we have to prescribe multiple for managing? Actually, every procedure has its own importance. It's not that one procedure is better than the other. It's the level of difficulty. Some vision therapy procedures will have one level of difficulty, and the next vision therapy procedures will have one level of difficulty. It's a matter that actually the therapy, as I discussed, can be either done as an office therapy procedures, or the therapy can be done as home procedures. So the tasks which the child finds easy, especially it depends upon the cognitive level of the child, the age of the child. So the procedures that the child find easy will be done at especially at the home, and the procedures that cannot be incorporated at the as an home therapy, we should incorporate that as an office therapy and perform. Or we have to prescribe or we have to prescribe for multiple for managing. Yeah, actually actually, for example, I'll just like to answer this with an example. For example, we have gone to the binocular therapy part, and always we do a Brock string. We ask the patient to do the Brock string at home also, and we ask the patient to we will do a Brock string as an office also. So that will be very monotonous to the child. So these different therapy procedures, we can either use all of them, incorporating some as an office and some as an home, so that it will be very much fun for the patient also. So what is the role of tint in treatment of amblyopia, and which tint I have to prescribe for my patient, and what is the principle behind it? Actually, I don't incorporate, there are theories regarding the importance of different teens in the child with amblyopia. Actually, not the child with amblyopia. The importance of teens has been very much highlighted, especially in the patient with brain injury and others, and also in patients with different neurological issues. But actually, I don't incorporate prescriptions of tint in these patient. So I hope that point also should be made into consideration and should be discussed in the further sessions. I'll just check that. So tint I don't prescribe. So basically there are a thing like some light blue tint. There is a tint called FL41 tint, 50% blue tint, amber or rose tint. And there are articles regarding the usefulness of some tints, but actually I don't use these tints in managing the patient. Actually, these tints can be used especially in the adults, I guess. In the child, I don't think there will be these tints will be. I have not incorporated these things, so maybe in the coming sessions I can answer that to regarding the usefulness of teens in amblyopia. So the next question is the next thing for discussion I see here is, if with vision therapy vision is not improving, then what should we do? In which case vision will not progress or improve? I think the question is the vision will not improve. So basically, if the amblyopia is functional amblyopia, so I'll just like to exemplify one situation in which the patient was referred to me. I guess there was a lady, 29-year-old lady, referred to me as an described as amblyopia, and her vision in one eye was 6/6 and the vision in next eye was 6/60. And on evaluation, actually despite her reduced visual acuity, and there was some deficient in visual functions, but on our dilated fundus examination, she had a macular congenital scar. I don't know. I could not rule out whether the scar was from the childhood or whether the scar was a recent in onset. So first, we need to evaluate a proper ocular health. So the visual acuity, we should to rule out whether the decrease in visual acuity is with the other any pathological or other any organic cause, and on evaluating or ruling out the other organic cause for a decrease in vision. So if or there is no any other organic cause, and the next thing we can go is how much the visual functions or the visual acuity has been improved, especially first from the spectacle corrections. So there will be some improvement with making the image clarity clearer to the retina. So it's not a point that if with VT vision is not improved. So let's go from initial thing. Let's make a concept that we should always approach from the first thing. So let's say, what about the improvement? What is the status of improvement from the spectacle corrections, the lens prescriptions? So let's go something like, what is the correction improvement in, does the visual acuity status or the visual function status improve with occlusions or not? And then only let's go for whether there is any improvement in visual acuity or vision with the vision therapy. So let's not first directly incorporate a vision therapy as your primary management plan. I request, let's go for the first with the proper lens prescriptions, and then with the occlusion part, and then with the vision therapy part. So I hope if the visual acuity is improved, some improved with the lens prescriptions, and there is some improvement of vision with the occlusion part, I hope the VT will be very much helpful. So how Syntonics improve amblyopia? Actually, the Syntonics part, I think, is a very vague concept, but I hope the thing that I can answer is, actually this Syntonics uses a different light filters, different specific wavelengths that stimulate a pupil, and this balance the autonomic and nervous systems of the body, and it improves the performance and different performance, or it helps in improving the stress or the performance of the patients in different vision therapy projects. It's not that only Syntonics will help, but incorporating a Syntonics will improve the performance of the patient. So these in these aspects, the Syntonics could help in the patients with refractive amblyopia. Also, I like to elaborate that the scope of Syntonics is very vague. It has been used in different aspects, like the patient with severe visual field loss, the patient with optic atrophy, the patient with the glaucoma. We can find very much thing regarding Syntonics, but in case of amblyopia, it helps in improving the performance of the child. Basically, it won't improve other things, but it will improve the performance of the child. So next question I can see is, what is the relationship between eccentric fixation and the visual acuity? Yeah, there is a relation, like with one prism diopter of eccentric fixation, the logMAR change relationship is there. And what approach should we take in case of behavioral refraction in the amblyopia? So what we need to do is, the main thing is full refractive correction. Sometimes we need to keep in mind that full refractive corrections sometimes, let's say sometimes or most of the time, won't help to the patient. So what we need to do is, we need to put a spectacle prescriptions and do some performance test, like the amount of separations, how that the incorporating the prescriptions will help in the binocularity of the patients. Will there be any change in the performance test of the patients? Like I'll just do two basic tests, especially in refractive and anisometropic amblyopia. If there is no strabismus, there is some gross stereopsis in the patient. So what I'll do is, I'll just check the status of stereopsis in the patients with and without incorporating a different amount of spectacle prescriptions, and see which spectacle prescriptions will have a good performance, or will have a good improvement in these test and then incorporate according to that. And the next thing is the one thing approach that I have basically started doing these days is incorporating some amount of plus prescriptions in the non-amblyoptic eye also. So what it will basically do is it will basically reduce the image quality in the non-amblyoptic eye, but the child will be able to do his all the daily life activities properly. Especially if the patient visual acuity in the non-amblyoptic eye is 6/6, I'll just reduce it to about not less than 6/12 or sometimes 6/9 parts. So because of that, the patient will not be able to will not have any decrease in his performance, academic performance and all of that. So what it will basically do is it will decrease the image contrast, or it will reduce the visual acuity in the good eye also, and the better and the amblyoptic eye will be able to properly compete with the good eye, so that the binocularity or the engagement, let's say marriage, can be attained. So the inhibition from the amblyoptic eye can be decreased. So the next question I see is, can you please explain what should we prefer, behavioral occlusion or the full occlusion in case of, let's not go with the full occlusion, especially if the patient is an adult. There will be very much decrease in compliance, there will be very much decrease in especially the quality of life, and I hope the adult will not be very much comfortable with going with the full-time occlusions. The behavioral occlusion, let's say either we can go for, if the child is or if the patient is first time presenting, we can go for a part-time occlusions like 2 to 3 hours of occlusions every day, incorporating a near activities like I told, the eye hand coordination activities, coloring or something like that. And then or if after the initiation of the active vision therapy procedures, let's just stop the occlusions and only use the occlusion as a minimal tool. And what I'll do is I'll just incorporate these occlusions especially in the monocular therapy procedures. And if the patient has been upgraded to, or the monocular activities are very much good in these patients, we have attained very much significant improvement in the monocular activities of the patient, we'll just stop that occlusions after initiating a MFV, monocular fixation in binocular field procedures and binocular therapies. Basically, we can go with this. We can make this approach in using occlusions in case of, let's say, adult as well as a child with amblyopia. So can I have a role of dopamine and levodopa in VT? How often it is used in clinical practice? I don't think the dopamine and levodopa, the role of dopamine and levodopa has been used in Nepal. So yeah, this the question, and this can help in answering some questions like the usefulness of syntonics in incorporating the incorporation of syntonics in the treatment of amblyopia. But no, I don't think we have the practices of syntonics here in Nepal. So basically, we can use, if we can incorporate the syntonics part, we can go with this studying these aspects. But if we don't have, so so sir, please explain about Heringer process. Yeah, Heringer process is one of the entoptic phenomenon. So Heringer process is one of the entoptic phenomenon, and it can be used to improve the. So why is this entoptic phenomenon is generated? Is that because of this xanthophyll pigment present in the macula has the properties of birefringence. So because of that birefringence, we see a double I don't know, I can't show you like this, double like structures, appreciation of these kind of structures. And we can, because and these appreciations of Heringer process can only be possible if the macula is fixating. And this Heringer process, this tool can be used in establishing a proper central fixation if the child or the person has eccentric fixation. So what is the best approach if we can do for isometropic amblyopia? Yeah, in correcting, so isometropic amblyopia or the patient with isometropic amblyopia, the approach is very simple. Just let's not make or don't make the full prescriptions. Just prescribe the same prescriptions on the both the eyes but make sure that improvement or that prescriptions will have some improve in performance test. So just to do some performance test as I discussed, like the Watford dot test and hysteropsis, because the isometropic amblyopia will have some form of hysteropsis. And let's check. And also one thing that we can do is check the near visual acuity status of the patients and prescribe depending on that for isometropic amblyopia. And in isometropic amblyopia, actually the binocular cells are not much that disturbed in the visual brain. So what my approach will be in this case of isometric amblyopia is, the first thing is the lens prescriptions. And actually the role of partial occlusion, let's say partial occlusion means the incorporating the plus or less more plus in one eye or other, it is no not we cannot do that in these cases of isometric amblyopia. So what my approach will be, I'll just prescribe the prescriptions based on the performance test and incorporate a part-time occlusions, like occluding one eye for one day and occluding one eye for day only for some period of time, let's say about 2 to 3 hours per day, until the patient comes for a next follow-up, until only the patient comes for next follow-up. And then on evaluating the patients after initiating vision therapy. And in these isometric amblyopia, the approach, the different approach will be that in an isometric amblyopia, we should make our much more work on the amblyopic eye, but in anisometric amblyopic eye, we should work on the both eyes. So the approach will be a bit longer, especially if we have to work on the right eye also and the left eye also. But in case of isometric amblyopia, again, one point to consider is that after the prescriptions of lens prescriptions also, there we can we basically find a significant improvement in visual functions of the patient. So that may be very much helpful. So the next question I see is how to do visuoscopy. Kindly explain the little bit briefly. So visuoscopy, we have the ophthalmoscope, either the Wells line ophthalmoscope or the Heine ophthalmoscope. On ophthalmoscope, there is a cobweb like structure fixation target. So what we do is we basically ask the patient to occlude the one eye. Always, as let's make a point to note that eccentric fixation is a monocular phenomenon. So what we do is we ask the patient to occlude one eye, and we project the ophthalmoscope light into the patient's retina and ask the patient to, we'll just give the instructions like let's say in any ophthalmoscope there is a central star and there is a cobweb like the ring concentric ring with a different prism diopter values. So after projecting the ophthalmoscope light to the retina, we ask the patient to see in that central of the star. So if the patient the fovea, or we can see a foveal reflex in that center of the star for some period of time, and there will be no any change in the no any placement of that central macular point, then we get to know that the patient will have central fixation. But if the patient on asking the patient to fixate on the central star, if we find that the patient, if we get to know that the foveal reflex is placed on different that concentric circles, we get to know that the patient will have central or the eccentric fixation, either nasal or temporal eccentric fixation, and we can calculate the amount. So next question is I have from Asmita. In case where individual have fairly good abilities of accommodation and eye movement and is a alternate suppressor, what do you take on the BT procedures? So if the patient is alternate suppressor, I hope that patient is a strabismic patient, Asmita. So especially in that approach, first we should go with the anti-suppression tags. First, in the patient with strabismus, our first rule, if the patient has good accommodation and eye movement, oculomotor abilities, and it is an alternate suppressor, we should first go for. We should first check what is the amount, and the main thing is we have to work on anti-suppression thing here. First, we have to eliminate the suppressions. So on eliminating the suppression, if the patient will have the fine, as we know that the final point in elimination of suppression is diplopia, and we can, if the patient will have diplopia, we can incorporate some amount of prism to have the patient go with diplopia, and we'll start the binocular therapy procedures and establish the binocularity in the patient. I hope that I will be able to answer.
Okay, thank you so much, Hira sir, for explaining all and every question. So, guess we have answered many of the question, right, sir?
Hello,
Yes, Ajit sir. Yes,
hello.
please.
Hira, this is Ajit.
Yes, yes, sir. We can hear you, please.
Uh, very nice presentation. I think you are very tired of this very long questions. Just I have one thought. I will tell this is thought. Uh, just when we talk, are you hearing, Hira? Are you there? Hello, Hira, are you there?
Okay, sir,
Hello,
I'll be. Uh, Hello.
hello.
So, Hira sir, can you please unmute? Yes, sir. I really brief after he came here. Just uh, you can
Is he
proceed.
Yeah,
there?
yeah, Ajita,
Brief
Ajita,
extensive.
Ajita, yeah, Ajita, I can hear.
Okay. Just I was asking. In your protocol, the first thing is the lens prescription, okay, and that
Yes,
just
yes,
I'm
yes.
fine with it. Lens prescription should be that which gives the best binocularity to the patient, best
Yes, yes,
binocularity, in which we are thinking of, as you told that we don't give full correction, means that the full correction concept is the old one. uh, we have to give that correction which gives him best binocularity. But when you come to
yes,
your therapy section, in which you first give monocular therapies, means
yes,
monocular session, the first therapy you start is monocular therapy, in which your monocular skills, monocular efficiency should be at its best. No, so my question is,
yes, yes, yes,
if when you start monocular therapies, I think for the therapy section, your corrections should be the best or the complete one, and for binocular, so it will be better if we have to give two pair of glasses for therapy section, for monocular therapy section, the one with full correction, and for others, for binocular, for others, other practices, there should be other. So, what do you think on that?
yeah. So yeah, very much good thought or intake on thought, Ajitai. But what I like to, I have a thought like is the full prescriptions is required, especially for doing monocular procedures like the oculomotor procedures and especially the eye-hand coordination procedures. I hope that if the child is very much performing, has good performance with that prescriptions on different performance tests, then that prescriptions
Even for accommodation.
yeah, yeah, yeah. My next thought is that for accommodation, we need to go with the full prescriptions. So in monocular therapies procedures, we don't let's not directly first incorporate or go with the accommodative procedures. First, let's go with different oculomotor procedures, and then eye-hand coordination procedures, and on again checking or evaluating the child, and then let's again go with the refining the prescriptions is if required, and then let's go with that accommodative therapies as a last part of monocular accommodative therapies. I hope that approach will be much better.
Okay. Good. Okay. 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 Fine. So one more queries. Okay. Just,
Okay then.
let's say if anyone has a vision, anyone has got vision 6 by 60 in his amblyoptic eye, and in better eye it
uh,
is 6 by 6. If
mm,
he is being corrected plus 6, plus 6, it is
mm,
636. Let's say it is plano,
mm,
plano, it is 6 by 6. So as you told, you will be overcorrecting the better eyes, that 6 by plus 0.5 to plus 1. Okay, and
Yes.
as you told, and you will be giving not plus 6, the one that is with best fusion range or best stereopsis, let's say 4 4. So my question is, why not degrade the better a little bit far? Why not giving plus 2 plus 3 in that good eye, so that visual will be around 618 612, and there will be 2 lines
So
difference,
yeah.
and the best correction. Yeah, you got it.
Yes, I very much a good thought. But the thing that we need to take into consideration is, will that partial occlusion in the non-amblyoptic eye has very much will have an effect on performance of the child. For example, if we decrease the visual acuity
Yeah.
to 6 by 18, I hope that child will be very much problematic during his academic activities. In your example, Dai, what I'll do is, what if the main thing, if the child has very much high amount of anisometropic prescriptions, so I'll just go with the contact lens in his left eye and
Mm-hmm.
incorporate
Yeah,
some the
fine.
partial occlusion in the spectacle prescriptions.
Okay. Okay, that's good. Okay, okay. Okay, okay. Thank you, Ira.
Okay, okay then. Thank you
Hello?
so much for participating. Yeah, Kapil.
I'm here. So I guess we have answered the many of the questions. So there are like sir, there are a new term, like people are using the juvenile uh, myasthenia gravis and amblyopia, and juvenile cataract type of amblyopia. Like they are using the juvenile words, like causing the any type of the amblyopia before. So is that only the clinical names, or is there another things that beside the another things that usually causing the amblyopia than usual things?
I guess that is a discussion regarding how the amblyopia is caused. The cataract, if the especially I guess that kind of amblyopia goes in the terms like form deprivation amblyopia. So basically, if we are basically focusing on a refractive amblyopia, isometropic and anisometropic will be the two basic term. But in case with the form deprivation amblyopia, like the visual acuity, reduced visual acuity is due to nystagmus, or the visual acuity will be due to the cataract. So I don't think that juvenile congenital terms is a much significant. We are very much concerned. What we should be concerned is not the using these terms, but let's I don't think that term is very much feasible. I hope anybody can use it, but I don't use it, Kapil. It don't matter what terms you use. Either you have a child with amblyopia. It don't matter what is. You should find what is the cause. But that cause of amblyopia or the cataract, or it could be ptosis. And our main focus, I guess, should be on the management part.
Hello, yes, sir, are you there?
Yeah, yeah.
Okay, we just okay, okay, sir.
Yeah, so thank you, Kapil, for providing me the platform for this session. So I hope these sessions could provide, I'd not say it provide all, could provide some basic insights into the different management plan of amblyopia, and the audience will have some different approach regarding how we'll manage the patient, especially the functional amblyopic patient.
Okay, sir. Uh, yes, it is very helpful for me. I guess it's all for the all Nepalese optometrists as well. Sir, if we start to treat the amblyopia, is it okay? But if we, I don't think there are very few guidelines that allow us way of treatment. But in your experience, which protocol you would suggest to follow to treat the amblyopia?
So basically, we should three. Let's go with
Is
the
there
three
any certain
basic
guideline?
things. There are not certain guidelines because the individual approach, because every amblyopic child is different. So actually, there is no such protocol thing. But what we can do is the lens prescriptions and the occlusions, and these the things I discussed, the VT, monocular, MFVF, and binocular. There is no such protocol about how to make the child. For example, I like to give you an example. There are two childs, both are with anisometropic amblyopia. One has 6 by 6 in one eye, and the next one has 6 by 36 in the both in the next eye. But some in one child, the visual deficits must be could be much more, whereas in the next child, the visual deficits must be could be much less. So the individual approach will be different, but the basic approach is the lens prescriptions. And if the, especially I'm talking about the refractive type, the proper lens prescriptions and the use of occlusions and the optometric vision therapy, I guess if we keep these proper framework, we'll be able to help a child a lot.
Okay, sir. Thank you so much, sir. I guess we have talked a lot, and it's been so long presentation. So we come so far with the knowledge of amblyopia, functional amblyopia treatment and management. So once again, thank you so much, sir. We want to hear you again and again, and what you provide us with this all knowledge, it's flourish our brain and all the Nepalese optometrists as well. Thank you so much, sir.
Okay, Kapil. Take care.
Have a good day, sir. Thank you so much. Herewith, I am ending the today's session. So requesting all you please provide your review and feedback. Thank you so much. Keep in touch and stay safe. Thank you.